no introduction. So, but still, I'll go through the process because I just like it's an honor for me. So our speaker today is Dr. Vivek Kute. He's a professor of nephrology and transplantation at the prestigious Institute of Kidney Diseases at Ahmedabad. And sir has done a lot of work. No matter what kind of transplant you think, his favorite work is with KPDs. He has done extensive work as Apex National panel member for deceased donor transplantation. He's a policymaker in his rights, and he has done a lot of national and international work. He's collaborated a lot. And for me, he's a big mentor for every small thing. So all everything he's like a mentor to me. And even this entire program is also a part of his hard work and his brainchild also. So today we'll be hearing from him on a very important subject. Now that we have gone through seven different lectures, and this is the eighth lecture on the immunology. So we'll be hearing about desensitization. So like now that we have gone through all the steps, the tests, the processes, and what is the report exactly. So when we're faced with a sensitized patient, it's sometimes very difficult to make those calls, take those decisions. So we'll be learning from Dr. Vivek Kute today, and his experience, his opinions, all the evidence that he has will present to us. Over to you, sir, for a brief introduction, and then maybe we can proceed for the recorded video. So can you briefly introduce the topic, sir, please?
So thank you, Subho, for the kind introduction. Today, we will be discussing the HLA desensitization, when we should do the HLA desensitization, and when we should explore the other options like paired kidney donation. So we will first go through the sessions, and at the end, I will be happy to take the question and answers. Can we start the session?
Yes, sir.
Thank you, ISOT, for giving me this opportunity to talk on how much to desensitize HLA sensitized patient and when to stop. First, we will see what is the overall organ transplant scenario in India. India is number 3 in the world for absolute number of organ transplants, only behind USA and China. Majority of the transplants are from living donation, that is 80 to 85%. And deceased donation contribute to 15% of the transplants, which is active mainly in the South and West India. Majority of the transplant services are available in the private sector, 70 to 80%, where cost is common concern. Even for ABO compatible transplant, death with functioning graft due to tropical infections is common, and these infectious complications are more common when we do HLA desensitization or ABO desensitization. So we have to provide a cost-effective, affordable solution for Indian patients. And also the age of ESRD in India is 1 decade earlier as compared to the Western world. So many patients need retransplant, and in that case HLA sensitization is very common problem. So HLA sensitization is barrier to access to transplantation in 20 to 30% of the ESRD patients. What are major causes of sensitization? These are blood transfusion, retransplant, pregnancy, and less common causes or minor causes like infections and chronic inflammation. How do we diagnose HLA sensitization? We have CDC cross-match, which is expressed in percentage. Then flow cross-match, which is expressed in median channel shift. Donor-specific antibody, by solid phase assay, that is Luminex platform, which is expressed in mean fluorescent intensity, and PRA testing. What does it matter? How we do risk stratification in case of HLA sensitization. CDC positivity is classical contraindication to the kidney transplantation, and DSA positivity increase risk for antibody mediated rejection, leading to inferior outcome both short term and long term. For the risk stratification, we have serologic memory and cellular memory. In serologic memory, category 1 is CDC positive patient. Category 2 is flow positive and CDC negative patient. Category 3 is DSA positive patient with negative flow and negative CDC. So this is the serologic memory. In cellular memory, we have absence of current DSA, but it could be the historical DSA. So all these tests are done for the risk stratification. The presence of preformed HLA antibody complicate the donor selection process, limit the pool of compatible donor, prolong wait time for transplantation. Then CDC positive is an absolute contraindication for transplantation. If we see the donor specific antibody, the ABMR is around 35% when DSA MFI is 3 to 6,000 and ABMR is 51% when DSA MFI is above 6,000. What is the outcome in living and deceased donor transplant? This is a collaborative transplant study from Europe. It clearly shows that outcome is better in DSA negative patients as compared to the DSA positive patient. DSA negative is blue and DSA positive is red. What to do to with the sensitized patient? All these tests like CDC, flow, DSA, PRA, they are used for the risk stratification so that we can choose optimal donor, optimal immunosuppression rather than prevent access to the transplantation. Is it better to stay on dialysis or to proceed with the desensitization protocol? What are the options for patient on dialysis? One is continue on dialysis, other is HLA desensitization, then ABO desensitization. So whenever we consider the long-term outcome for kidney transplant, DSA negative ABO compatible has better outcome as compared to ABO incompatible. Second, ABO incompatible has better outcome as compared to HLA incompatibility, that is the sensitized patient. Then outcome of living donor transplant is always better than deceased donor transplant, and outcome of any desensitization is always better as compared to continue on any form of dialysis, either peritoneal dialysis or hemodialysis. Is the outcome different according to degree of sensitization? The first group is positive multiple bead assay and negative flow cross match. The second is positive flow cross match and negative CDC cross match. And third is positive cytotoxic cross match. If we consider any combination of CDC, flow and DSA test, the outcome of any desensitization therapy is always better as compared to the dialysis therapy, which is having the morbidity and mortality. Then outcome by assay type and antibody class. So the worst outcome is seen with CDC positivity, and better outcome is seen with DSA positive and negative flow cross match and CDC cross match. One of the common practical group is DSA positivity, where we can proceed with desensitization therapy as per the strength of donor specific antibody. Then graft survival by donor specific HLA antibody specificity. So this figure shows that if only class 1 is positive, the outcome is better as compared to class 2 positivity. And outcome is worst when both class 1 and class 2 HLA antibody are positive. Then modalities of desensitization. The first modality is extracorporeal therapy. That is removal of HLA antibody. That is plasma exchange or immune adsorption. The second modality is inhibit production of HLA antibody. This include B cell inhibitor, that is rituximab, which act on CD20. Then plasma cell inhibitor, commonly uses bortezomib, that is proteasome inhibitor, and tocilizumab, that is acting on IL-6. Then complement inhibitors, commonly uses eculizumab, C5 inhibitor. However, the cost is higher and availability of the molecule is concern for the Indian scenario. And recently added is the imlifidase, that is IDase, which act on IgG cleavage. And all of us are aware about the pooled intravenous immunoglobulin acting on multiple sites. Then extracorporeal therapy, that is plasma exchange. We have standard plasma exchange or double filter plasma exchange. Plasmapheresis achieve antibody removal by extracorporeal filtration of plasma, separating it from cellular component and allowing selective removal of immunoglobulin. High flux membrane enable efficient clearance of antibody, including anti-HLA antibody, while preserving essential plasma constituents. Then immune adsorption. Similar to plasma exchange, this technique remove antibody by binding them to specific adsorption column and has emerged as a leading technique with apheresis options for desensitization. It offers several advantages over plasmapheresis, including more targeted antibody removal, improved efficiency in clearing immunoglobulin, eliminating requirement of plasma or albumin replacement. Compared to the plasma exchange, immune adsorption is 4 to 5 times more effective. Then drawbacks of extracorporeal therapy. Their limited capacity to remove preformed antibody, heightened risk of infections. To mitigate this issue, there are often supplemented with anti-B cell therapy and intravenous immunoglobulin. So what is IVIG? They contain diverse array of polyclonal antibody derived from poor human plasma, which exert multifactorial effects. Neutralization of circulating antibody, inhibition of B cell activation and differentiation, modulation of cytokine production and cellular interaction. These mechanisms collectively contribute to reduction of DSA and attenuation of alloimmune response. These are the available publications on plasmapheresis and low dose IVIG, that is 100 mg per kg, what we commonly use in clinical practice, versus high dose IVIG, that is 2 gram per kg. They are showing this is the data mean follow-up, AMR, patient survival and graft survival. So by and large, outcome of high dose versus low dose IVIG is comparable, because in Indian scenario we have to calculate the cost of IVIG. So we commonly prefer a low dose IVIG. So major trials, no one approach or modality has proven to be consistently superior. An individual approach considering patient profile, resources available, physician comfort plays a crucial role in deciding treatment for particular patient. So no one size fits all policy, tailor regimen as per available resources, patient profile, and we must consider the financial aspect when we want to start the desensitization protocol. Rituximab therapy, it acts on CD20 molecule. Then it prevents DSA formation. DSA is a risk factor for antibody mediated rejection. Nowadays, there is a trend towards decreasing the dosage of rituximab, and we usually give minimum 200 mg and maximum 500 mg dose of rituximab, because infections are very common when we combine rituximab therapy with thymoglobulin induction therapy. Proteasome inhibitor, the commonly used is the bortezomib. The dose of bortezomib is 2 mg dose. It can be given intravenous or subcutaneously. One cycle of bortezomib include 4 doses of bortezomib, and we can give minimum 1 cycle and maximum 2 to 3 cycles for the desensitization protocol. The common side effect with the more cycles of bortezomib is the neuropathy, infections, diarrhea, but we can manage them with the symptomatic therapy. Then IDase. IDase is a IgG endopeptidase derived from Streptococcus pyogenes, effectively deplete anti-HLA IgG. However, this effect is short-lived, lasting for few days. Though short-lived, this creates a therapeutic window for successful retransplant in sensitized patient when combined with other strategy like rituximab, IVIG, and proper induction therapy. Study published by Jordan with use of IDase. This is a data of 25 patients. Mean follow-up is 5 months. AMR is 20%. Patient survival is 100%. Graft survival is 96%. But currently IDase is not available in the Indian scenario, and also access to the eculizumab is very limited. Then cost consideration. Medication. The cost of medications like IVIG, rituximab varies widely depending on dosage, brand, insurance coverage. Procedures like plasma exchange and immune adsorption incur cost associated with the equipments, personnel, and facility fees. Hospitalization. Depending on intensity of desensitization, patients may require hospitalization for monitoring and treatment administration. And laboratory testing. Regular monitoring of antibody level through blood test adds to the overall cost, because even after desensitization, we need to monitor the DSA, especially during the early post-transplant period. So what are the cost of commonly used medications? This is the cost of available in our public sector hospital. Yeah. And what are the cost of commonly used tests? HLA typing cost around 20,000. Single antigen beads cost around quantitative tests around 30 to 33,000. PRA testing is 13,000. lymphocyte cross match is around 3000, and flow cross match is around 7000. So cost is prohibitive for a common man when we want to start the desensitization therapy, because in private sector patients don't have universal insurance and they need to pay from their pockets. Then duration of treatment. Defining optimal duration is challenge. So we need to see the severity of sensitization, specificity of antibody, immunosuppressive strategy, and affordability. So what are the different protocols available for the desensitization therapy? We are aware about the CDAR-SNI protocol. In step 1, they use IVIG and rituximab. If cross-match is acceptable, they proceed for transplant. And in step 2, plasma exchange is added as a rescue therapy in the CDAR-SNI protocol. This is the protocol published by Montgomery, where they use plasma exchange and IVIG in the first step. If the patient become transplantable, induction therapy with IL-2 blocker or ATG, and rituximab is given for very high strength DSA or for retransplant. Then how to approach a sensitized patient? First, we should see what is the CPRA. If CPRA is 30% or more, we should see whether the living donor is available or not. If living donor is available, we can do CDC cross match, flow cross match, donor specific antibody, and virtual cross match. If CDC cross match is positive, it is a contraindication to the transplantation, and we should go with the alternative donor or paired kidney donation or deceased donor transplantation. If CDC cross match is negative and flow cross match is positive, we should see what is the positivity. If the median channel shift is above 250, we should go for KPD or alternative donor or desensitization. And if the medial channel shift is below 250, we should see what is the RIS value. If the RIS is above 17, again patient is difficult to desensitize, and we should go for KPD or alternative donor or deceased donor transplant. And only if the CDC cross match is negative, flow cross match is positive with MCS below 250 and relative intensity score below 17, these patients we should desensitize with IVIG, rituximab, plasmapheresis, or immunoadsorption. If patient don't have living donor candidate, and if he is likely to get deceased donor transplant in 1 year, then we should consider desensitization therapy. If transplant is unlikely within 1 year, we should not start the desensitization therapy. Then what is the relative intensity score? No DSA will be given 0 points. Weak DSA, that is MA5 below 5000, they will be given 2 points per week DSA. Moderate DSA, that is 5 to 10,000 MA5, 5 points per moderate DSA. Strong DSA is MA5 above 10,000, and 10 point will be given for each strong DSA. So we should calculate the RIS, and if RIS is below 17, then we should able to do desensitization therapy. If RIS is above 17, we should not do desensitization therapy. What we follow at our center. I am working in a public sector hospital where cost and infectious complications are common concern. So for any kind of positivity, either CDC, flow cross match, or DSA positivity, we always try first step as a paired kidney exchange. If alternate donor is available, we also explore that option before registering patient for the deceased donor transplant. So out of total 560 paired kidney exchange transplants in our center, 20% patients join swab transplant because of positive sensitization, HLA sensitization. We always try to prevent desensitization therapy in case of flow positivity, but we should try the desensitization therapy when CDC and flow cross match is negative, but only DSA is positive, that is low strength DSA. Points to remember: expertise of center in performing desensitization procedure, availability of another compatible donor or paired kidney exchange program, or feasibility for getting early transplant in 1 and 2 years in deceased donor transplant, the individual risk of infection and ability to tolerate heavy immunosuppressions. So we have to calculate the pre-transplant infections, financial constraints, including capping of government supported schemes, because we do transplant in Ayushman Bharat scheme, and they provide 5 lakh for the kidney transplant in Ayushman Bharat scheme. Then time on dialysis and urgency of kidney transplant. So also we should have a robust HLA lab available for getting standard reports. So when we should not do desensitization therapy. So to decide this, we should understand what is meaning of PRA. PRA is ability to match. Patient might have very high strength DSA to one particular antigen but low PRA. Blood type also affect ability to match. For example, O donor or AB recipients make pair easy to match in the paired kidney exchange. And what is DSA? DSA is ability to desensitize. Patient with many antibodies might have low strength antibody to a particular donor antigens. So this is the table showing when we should not do desensitization and when we can do desensitization. For a patient with low PRA and low strength DAC, we can try for the KPD. If KPD is not possible, we can do desensitization because DAC is low strength. For patient with low PRA and high strength DAC, we should try the KPD. Here desensitization is difficult because of high strength DSA. For patient with high PRA and low strength DSA, KPD is feasible, and if KPD is not available because of single center practice, we can go for a desensitization only with the low strength DSA. And this is the worst combination, high PRA and high DSA. Here we need to combine desensitization with the paired kidney exchange. So what I want to give you message that desensitization is possible when strength of DSA is low. With high strength DSA, failure of desensitization therapy is likely. This is the outcome of our single center kidney pair donation program. So far, we have done swab transplant in more than 550 patients. 20% of our patients join paired kidney exchange because of positive HLA sensitization. And when the donor pool is large, or we have the computer allocation for the swab transplant, then we can give better quality of matching for the sensitized patient. The outcome of swab transplant is similar to any ABO compatible DAC negative transplant, and our outcome is acceptable over a long-term follow-up. When this is the multi-center cohort study about paired kidney exchange from India. This is a data of 1839 swab transplants. Unfortunately, only 5.5% of the patients join this in this registry are sensitized patients. So we must understand that the swab transplant is logistically complex procedure, although this is medically simple. So we have to see the feasibility of the swab transplant when we provide options to the sensitized patient, so that the patient can take informed decisions considering the projected waiting time in case of swab transplant. Now it is time to start the multi-center program and national program, so that we will increase the donor pool, and with use of computer allocation, we can provide a better quality of matching for the sensitized patient. So we should always try the feasibility of swab transplant in case of sensitized patient. Thank you for your attention, and I welcome all of you to ISOT 2024 at Ahmedabad from 17 to 20 October.
Subho, kindly unmute.
Okay, sorry. So that was an excellent overview of the desensitization protocols across the world and at our own center. So I think we have a few questions in the background. By the time I'll just finish some of the questions that I have in mind. So what is your typical approach to broadly sensitized patients? Suppose, I mean, you have explained a little bit, but I'll still want you to clarify. Suppose, I mean, there is a lot of PRA, those with say 95% or more PRA. So do you think desensitization is the way forward in these patients, or like KPD, or waiting for a, I mean, disease donor transplant? What exactly do you practice, sir?
Yeah, the most common clinical problem which we encounter is the DSA positive and flow and CDC negative. In this case, by and large, if the DSA is below 5,000, we can proceed with the desensitization. We can proceed with the transplant with available options in the desensitization therapy. But if the DSA is positive and also flow is positive, we need to check the MCS. If MCS is high, like about 250, we should try to avoid the desensitization, because more intense desensitization therapy is required in this case, and outcome is inferior in this scenario. So in our day-to-day practice, we always see the paired kidney exchange is feasible or not. For example, yearly we do around 400 transplants. 1/3 of the donors are rejected either because of ABO or HL incompatibility, and they can be easily managed with the single center program. But for the swab transplant, the donor pool is very important. If swab is not feasible, we should go for the desensitization therapy.
And sir, like we have a RIS like system where we can actually now look at the number of DSAs and count and give them a score for those who are going for a living donor transplantation. But we don't have a similar system for those with those who are listed for disease donor transplantation. So again, like you explained, so are you looking at the number of DSAs, the breadth and height, I mean the intensity of the DSAs, and then deciding for those for disease donor?
Yeah, so desensitization in case of disease donor transplant is a very important decision. It also depends what is the state allocation policy in case of disease donor transplant. In certain states like Gujarat, the patient gets priority for the PRA positivity, HLA antibody positivity. And in many states like West Bengal, Karnataka, Rajasthan, Kerala, where allocation is based only on the seniority points. So we should see what is a projected time required for patient when he is listed for the deceased donor transplant. If he is likely to get deceased donor transplant in 1 year, then we can consider some form of desensitization therapy as per the available values for the FCM, DSA, and PRA. But in many states, a deceased donor transplant is not active. Standard waiting time is like 2 to 3 years. In that case, it is not wise to start the desensitization protocol because patient is unlikely to get the transplant. So this is very important. But by and large, the desensitization is carried out where when patient is having the living donor, so that when the reports are acceptable, we can proceed for living donor transplant. In case of deceased donor, it is very challenging if the reports are acceptable, DSA come down with the given treatment and there is no donor available, patient has to wait for a long time.
Okay, so we'll take some of the questions also. So do you think how often after desensitization protocol do you monitor the DSAs actually, because that's a very costly test, around 33,000 as you said. So how often would you monitor, and like once you've finished desensitization, would you still go for a repeat DSA monitoring, I mean single antigen bead assay, and then go for transplant, or once you've finished and the patient's cross matches are negative, would you want to proceed for the transplant?
Yeah, it is ideal that DSA should be repeated at the end of desensitization therapy before we proceed for transplant. But in the Indian scenario, we must see what is the cost required, whether patient is affording. Once we do the transplant, it is advised that DSA should be repeated at the interval of 3 to 4 months after transplant, especially during the first month, because the AMR are common in the initial time period after transplant. Once grafts settle down, then we can do DSA monitoring only in case of rise in creatinine. But especially during the initial 6 months, I will definitely like to monitor the DSA even without graft dysfunction.
And would you treat such a situation, sir? Like suppose the DSAs are rising and the creatinine is still stable. So, I mean, what are the
Again,
options?
yeah,
Yes.
we need to see whether this is a C1q binding. If and then we should definitely the DSA abrogation is required whenever there is a rise in DSA. Because creatinine is the end result. When creatinine rises, there is a histopathological damage in the allograft. So definitely DSA abrogation is required either with the bortezomib and rituximab. And definitely we should see if there is a creeping creatinine, plasma exchange is also added at that time.
Okay. There's a question from one of the attendees. Like you've explained about CPRA and how is it used in the deceased donor transplantation. It's not used in the live. I mean, the question is like whether it is used in live. So it's not used in live. So how is it used in deceased donor kidney transplantation?
Yeah, this is very important that the PRA test is mainly for the deceased donation and not for living donation, because PRA is ability to match. When patient come with a single donor, there is no utility of doing the PRA. The only advantage is the lower cost as compared to the DSA. So PRA and CPRA, they are useful only for the deceased donation, and these kits are not standardized for the Indian patients. I have seen many patients that when they get different PRA reports with the different labs, one patient get 50%, 80%, 90%. So we have to calculate the CPRA and get the current judgment about the level of sensitization for these patients.
Sir, there is a little bit of publication that if the patient is having non-DSA antibodies, so the outcome is also not very good for them. That these antibodies like CDC negative, flow negative, and DSA negative, but non-DSA positive. So they have anti-HLA antibodies, but not for the same. So there is some. I was reading in UpToDate that there are some indications for actually doing some amount of desensitization in those patients. So do you agree with that? And or is that not valid for India?
Yeah, the results are very variable. When we want to see what is the long-term impact of HLA antibody which are not DSA. But we need more studies and robust evidence whether we should treat the non-DSA HLA antibody. Because many time the DP are very common in second transplant, and non-DSA HLA antibody, they are also very common in second transplant. And in Indian scenario, the common age of ESRD is like 43, 45, which is almost 1 decade earlier as compared to the Western standard. If we want to chase this HLA antibody which are not DSA, the cost is very important. The infectious complications of added any form of uh, rituximab or plasma exchange is very important. So I will not prefer to chase the non-DSA HLA antibody.
And one final question I'll take, sir. Do you think there is a role for protocol biopsies with the current immunosuppression scenarios in such patients, for those who have undergone transplant after desensitization in some form? So would you like to do protocol biopsies in these patients?
Definitely, first and most practically advised is the DSA monitoring, even if the graft function is normal. We do advise the protocol biopsy, especially in the high-risk patient. But many times the patients are very reluctant for the protocol biopsy. So it is difficult to convince them, but they provide some added advantage to decide about the risk stratification. And if the protocol biopsy is showing immune injury, we can monitor the intensity of maintenance immunosuppressive therapy. And so protocol biopsy do have the role, but patients are not very convincing for doing the protocol biopsy, but they easily do the DSA monitoring, although this is a costly affair.
I think we have taken most of the questions, and for a few we have written out the answers, which were specific and already taken up by Vivek sir during his talk. So I think we can close the session now. So thank you, sir, for joining us, for giving us your time. And it was many people have commented that it was such an excellent talk with a beautiful overview of the entire process and a brief look at the KPT work also. So thank you, sir. Thank you, ISOT team, for having us. And thank you all the attendees for joining today.
Thank you, Subho. And thank you all the attendees for your valuable time.
Have a good night. Thank you.